Thank you everybody for coming, and just a comment on the time. I'm going to be very prompt and very respectful of everyone's time, so we will finish at 6:30 and not a minute after. In terms of questions, let's hold questions to the end. I'll try and end a few minutes early so we do have time for questions, and then I'll stay a few minutes after, but apparently not past 6:45 when the lights are going to be turned out. So we'll go from there. My name is Dr. Allison Muller, and I've been a toxicologist about 23 years now. I spent the bulk of my career at the Poison Control Center at the Children's Hospital of Philadelphia. I was their managing director for 10 years. Currently, I do independent consulting, both for medical education, so teaching physicians how to take better care of their patients, also pharmacist education, and expert witness work for attorneys in my specialty area of toxicology. So this talk grew out of many questions that I've gotten from attorneys about medications, and when I'm going through these medical charts that I've given for cases that I'm involved in, I've kept a running list in my head of things that I see, of red flags that I see, that I wanted to teach attorneys about that they can also pick up. Now, so I kind of set it up as, you know, these are some red flags, these are some things that you want to look for when you're looking at medical records, because medical records can be very voluminous and can be also very secretive in many ways, and really being able to ascertain if there's been harm done to a patient, whether you're on the defense side or you're on the plaintiff side. Of course, I'm working on both types of cases and things that you can benefit from this talk. I'll talk a lot about safe dosages of medication. I mean, as a toxicologist, one of my main focus would be to see that there's been a safe use of a medication, a safe use of a chemical, or what the range would be for safety and how you would determine that. And some final points, and you should have some handouts. If you don't, I'll make sure you get them electronically, but I believe Dan has taken care of this. There's 2 handouts that I have for drug information sources for attorneys, and then just a summary of the tips. So these 10 tips, so things to ask yourself when reviewing a medical chart, drug information resources that I personally recommend because I know that they're clear and they're reliable and they're made for non-healthcare professionals. Things about drugs that are some nuances, whether it be a class of drugs that we'll talk about or some specific drugs. Who are the patients that you really have to have your concentration on in terms of why they're more likely to have a problem with a drug or a class of drugs? It's not only pediatric patients or the elderly, it's not only an age thing, there's also some other factors that make certain patients more sensitive to harm from drugs. Something called the FDA prescribing information. What is that? What does it look like? Where do you find it? And why do you care about it? And then finally, when to consult a medical expert. Because remember, you can do a lot of things on your own before consulting a medical expert. So to put some things in perspective, I have a few slides on statistics. These are just statistics that really grabbed me. So this isn't too surprising. So the latest prescription statistic that I had in terms of how many prescriptions are filled in the United States was back in 2009, 3.68 billion prescriptions filled in the United States. That wasn't a surprising number to me. I mean, yeah, when I go to the doctor every year for my cough, my cold, whatever, and I don't come out of the doctor's office with a prescription in my hand, I'm disappointed, right? I mean, you just feel like you go to the doctor, you spend time to go there, and you think, I think not with the prescriptions. So yeah, there's a lot of prescription writing and a lot of prescription filling going on out there. And in terms of a number of prescriptions that adults in the United States are actually taking, nearly 70% of adults are taking at least one prescription drug, and more than half are taking at least 2. And what are the top 3 classes of prescription drugs that we're seeing? Antibiotics, not a big surprise. There's of course a lot of controversy, are antibiotics being used appropriately? Are they being overused? Are they causing more harm than good? And there's a lot of issues with that. Antidepressants is a very large class of drugs, certainly larger than when I started pharmacy school in the late 80s. And there's antidepressants, there's many classes of antidepressants because there's many reasons for an individual patient's type of depression. And one drug will work for one patient, another drug will work for another patient. And then finally, opioids. You can't throw a stone nowadays without hearing about opioids in the news, whether it be because of the opioid overprescribing or the heroin epidemic or all the deaths due to opioids. But in terms of prescription opioids, we're talking about pain medications, so prescription things like Vicodin or Percocet, oxycodone, Oxycontin. And then 1 in 10 Americans take 5 or more prescription drugs. So if I go around this room, if we have 20 people in this room, so there's 2 of us that are taking 5 or more prescription drugs, which is a staggering amount. So that just shows you there's a lot of potential for error, potential for adverse effects, potential for drug interactions, potential for harm when there's that many people on that many different types of prescription medications. So what are some other interesting statistics about medications? Well, a review of death certificates for the period of 1976 all the way to 2006, there were 250,000 deaths due to hospital medication errors. Now let's put this in perspective. So these were 62 million death certificates. And for this time period, there was 250,000 deaths due to hospital medication errors. And this is errors. This is meaning mistakes, like the wrong dose was given, the wrong drug was given, drugs that were not supposed to be given together were given. So these are errors. These are not adverse effects, like somebody who was on a drug had something bad happen to them, but it was given properly. In this case, it was the drug was given improperly. And the deaths spiked by 10% in July in the larger academic institutions. Now, what's so special about July? Why were the deaths due to medication errors spiking in that month over this time period? Anybody hazard a guess?
That's when the new crop of interns come in.
Yes, exactly. That's when the baby doctors start. That's right. So they're physicians, they're just not experienced physicians. That's exactly right. And then what about preventable medication-related adverse effects? That's what you're interested in as attorneys. What could have been prevented? And when we say adverse events, adverse events mean different things to different people, but for me, it means something that went wrong in the most simplest of terms. So almost 500,000 preventable adverse events related to medications happen every year in the United States. When I look at these statistics, it makes me realize you don't want to be in a hospital. Maybe you want to work in a hospital, but you don't want to be a patient in a hospital with all the deaths that occur due to medication errors and the injuries that occur in America's hospitals because of medication injuries. And the Institute of Medicine reports that a typical hospital patient is subjected to an average of at least 1 medication error per day. I've had family members in the hospital. You've all had family members in the hospital. I tend to spend a little bit more time bedside with family members in the hospital as the person that they wish, or at least their medical staff wish was not there, because I'm the one who's like, well, let's take a look at the medication review for today, or let's take a look at the medical records, of course, with the patient's permission. And it really was every day. I remember when my one family member was in the hospital, every day there was something else. And I was doing this remotely. So family member was up in New York, I'm here. He gives me access to his medical records. Every day I call, see how he's doing. Before we get to the see how you're doing part, I see on your chart it says you're not supposed to have any blood thinners. Do you realize they've been giving you aspirin every day? No, I didn't know that, but okay, now I'm going to talk to him about it. And the next day, it'll, look at the chart and it clearly says, not supposed to, or it'll say statin drugs contraindicated due to severe reaction, which basically means these certain types of drugs for high cholesterol are bad for this patient. I'm looking at the chart, they just started him on lovastatin. Another little phone call, did you know they're giving you lovastatin? When you're the patient in the hospital bed, you're taking the medications, you're resting, you're trying to get well, you're not sitting there reconciling your medications, or you might not even know what medications you were not supposed to be getting or the right dose. You need someone to look out for you, you need that advocate. So I can say from personal experience that is not far-fetched that a typical hospital patient has the average of at least 1 medication error per day. Getting a medication they're not supposed to, getting an incorrect dose, getting things that are interacting with one another. So where do these things happen? Doctors are smart people, pharmacists are smart people. Like what exactly is happening? This is not a new phenomenon in terms of medication misadventures and harm to patients. Well, there's many steps in this process where things could possibly go wrong. And I used to teach medication safety when I was at CHOP, and one of the analogies that we would use, if you think of several slices of Swiss cheese all stacked up together, if you go from one piece to another, you're going to hit the next piece, so you have a stopgap. But if all the holes in the cheese were lined up exactly in the same place, it's going to go right through. And that's what happens with medication errors at times. There's no stopgap there. There's one person misses the error, the next line of defense misses the error, and so forth. So these are the different lines of defense. So first, the medication is ordered. So in other words, the physician or the prescriber, whether the nurse practitioner or physician assistant, orders a medication. So whether it be a paper or an electronic prescription, was the prescription written correctly? Was it written for an appropriate dose for that patient? Was it an appropriate drug to be given when the patient's on other medication or has medications or has disease states where maybe that drug might be a problem to give either at all or in that dose? Then when it comes to the pharmacy, the pharmacist's role is to verify that the medication is appropriate. So the pharmacist should have as much information as possible to verify that yes, this is an appropriate drug for this specific patient. And then the drug is dispensed, meaning the drug is given to the patient. Now, either it's given to the patient bedside or it's given to the patient when the patient or caregiver goes to the pharmacy. And you think, okay, well, how hard could that be? You just give the drug to the patient, it's already been ordered, it's already been verified, now it's just being dispensed to the patient. And I can remember one very serious case when I was at the Poison Control Center about an adult patient who had been undergoing hemodialysis, meaning his kidneys were not working as well as he needed them to, so he needed to supplement his kidney function with dialysis. And when he would have the hemodialysis, sometimes he would be, really tired and he would sleep the rest of the day. So his family really didn't think much of it. So he was supposed to get 3 prescriptions filled at his neighborhood pharmacy, and he had a family member go and pick up his medications. Now, let's say his name was John Smith. So they, okay, Smith, they get the medications, they put the 3 medications in the bag, and off he goes. He doesn't think to look, okay, do these say my name on it? Are they, the right medication name on the label? Are they the same color? Are they the same shape? He's not feeling well to begin with, so he takes the 3 medications. Unfortunately, these medications were not for John Smith, they were for Jane Smith. Of course, I'm making up the name, but this is literally how close it was. So they were for a completely different patient. And one of the medications was for Jane Smith, who was a diabetic. This man, John Smith, was not a diabetic. John Smith took 1 pill, an anti-diabetic agent that was meant for somebody with diabetes. Again, he doesn't have diabetes. It lowered his blood sugar so much, and again, we didn't expect him to be, arousable, and he was pretty sleepy anyway. He was never aroused the next morning. His blood sugar dipped to 0 overnight with just 1 pill meant for another adult, but with diabetes. And this gentleman ultimately died from hypoglycemia crisis. So it's, this was just a matter of, maybe he was a high school student, just like getting the bag and gave the wrong bag to the caregiver, and then that resulted in death from a medication that was not meant for that patient. And then administration of a drug, so administration occurs in the hospital. We're not administering drugs unless you include vaccines in a community pharmacy. So you can see where errors might occur there. Administration of the drug has already been verified, has already been ordered, has already been dispensed, and now it's being brought to the patient in their room. Is there a check of the bracelet to make sure it's being given to the right patient, and that the right amount of drugs were brought up to the floor. So you can see where things can go wrong, resulting in overdose, resulting in interactions. And in the surgical suite, it's even more serious because you have 0 room to play with when you're talking about drugs that are delivered intravenously. Even if it's an error that is caught right away, depending on the drug, it may result in permanent harm, if not a fatality. So we talk a lot about the medical chart. And the medical chart definitely only tells part of the story. Many medication errors are going to go undocumented and unreported. Even though, like when I did my safety training at CHOP, and I would teach class after class about preventing errors and how to address errors when they occur, to tell my students, you will make a mistake in your career as a pharmacist. You absolutely will. And all gasp, but no, you will. It's human error. You will miss something. But it's a matter of how serious of a mistake did you make? And what did you do about it? Did you tell somebody right away? Did you refer, let's say it was a community pharmacist, did you refer the patient to the emergency department? Did you refer them back to the prescribing physician? Did you get involved, or did you try and take it on yourself to, cover up the error and send the patient on their way? So this just cause safety culture is, supposed to tell those in healthcare that, hey, things are going to happen, errors are going to happen, and patient safety comes first, and there's not going to be any sort of punishment or discipline for errors. I mean, that's partially true, but there's all different types of errors, and we're not going to go into the types of errors in terms of, which ones are reckless, which ones are human error, which ones are due to at-risk behavior or understaffing, those types of things. But you're not going to see in a medical chart wrong dose given to patient, interaction with these two drugs. It's never going to be black and white like that. And that's why I thought it was so important to educate about what kind of things you can look for in medical charts to really tell you, is there a case here? I mean, is there a situation where there was an error, or the error that I'm hoping didn't happen, did it happen when I'm looking through these charts? So I mean, there's different things on the medical chart that you can dig up. So first of all, there's patient compliance, or some people use the term patient adherence, which means, is the patient doing what they're supposed to be doing? Are they taking a medication as prescribed, as directed? Sometimes we're able to ascertain that, sometimes we're not. I was involved in a death case, and this was pretty unusual that in this particular case, not only did I have post-mortem, which means after death, drug levels for this particular patient, but when EMS had gone to the woman's house, they took the extra step and saw all of her medications, all these random pill bottles on her table, and they put them all in a paper bag and took them to the hospital. And it was very easy to figure out, and this was documented in the medical record, I was not there, that this woman was not compliant with her medications because she had, let's say, a Tylenol bottle, and she had, 6 different color medication pills in there. So she was keeping pills in bottles that didn't belong there. She was also clearly taking drugs that were discontinued by her physician months ago. So now she was on drugs that she was not supposed to be taking anymore with the new drugs that the physician started. The physician's not realizing that she never stopped as she was supposed to with those drugs. So sometimes you have some information on patient compliance, sometimes you don't. I rather see a stack this high of medical records than to get like a really compact package in the mail in terms of medical records and pharmacy records. The more records I have, the better, because it paints a better picture of, what drugs were they taking? Were they going to multiple pharmacies to get different drugs dispensed? Were they seeing different doctors? The more records, the better to really tell you the full story. And I mean, with some drugs, the pharmacies can talk to each other. So we have a prescription drug monitoring system in Pennsylvania. Those are for controlled substances. So controlled substances being like narcotics or tranquilizers, those sort of things that have a federal schedule to them. But if they're going to different pharmacies and they're getting, let's say, an antidepressant here and an antibiotic there that interacts with it, we're not going to know that unless we know all the pharmacies that they go to and we have all the records from that. So when I talk about if a patient should have gotten a medication, so the most obvious thing was, did they get the right drug to begin with? Like John Smith, he clearly didn't get the right drug dispensed to him because he picked up Jane Smith's prescriptions. So that's the most cut and dry scenario. But then there's some other factors, like, so somebody has certain medical conditions. Well, things like if they have something called congestive heart failure, so their heart just isn't quite working as strongly as it could, they want to avoid drugs in the class of calcium channel blockers. So where are we catching this? If the physician writes for a calcium channel blocker and this patient is taking a calcium channel blocker, did the pharmacist notice this? Did the pharmacist know about the patient's medical history? So these are things that are not necessarily absolutely can't give a calcium channel blocker with congestive heart failure. Maybe there's more to that story. Maybe the physician had tried multiple other classes of drugs and then ended up with the only choice of a calcium channel blocker, or maybe the physician is closely monitoring it. These are the kind of things I want to know when I'm looking at a medical chart, because sometimes there's drugs that you absolutely cannot give with certain medical conditions, and then there's ones that are dangerous to give with medical conditions unless there's a physician or other healthcare provider that's closely monitoring. Things like non-steroidal anti-inflammatory drug, NSAIDs. So there are prescription NSAIDs, there's also over-the-counter NSAIDs like Motrin or Aleve. And people who have chronic kidney disease should not be given those drugs because it could easily worsen their kidney disease. So you're thinking, no, wait a second. If I'm taking an NSAID like Motrin, for my headache, why do I have to worry about it affecting kidneys? Well, drugs do not work exactly where you need them to work or exactly where you want them to work. They have effects all over the body. So for example, drugs like NSAIDs decrease the amount of blood that's flowing through your kidneys. So if your kidneys are not working well to begin with, and now you're decreasing the blood flow, now you're making your kidney function even less effective. So it's things like that. People who, like this family member that I had mentioned, had an increased risk of bleeding for one reason or another. The last thing you want to do with someone who has an increased risk of bleeding, whether it be because, let's say, they have peptic ulcer disease, is to give them a drug that can make it more difficult for them to thicken their blood and clot their blood. So somebody who has peptic ulcer disease, you don't want to be recommending that they take aspirin or any other sort of blood thinner. They have enough issues with bleeding as it stands. Was a medication appropriate for a patient? Now, one of the things is the drug-drug interactions. Now, some things you're going to know about and some things you're not going to know about because you don't always know about what dietary supplements, herbal medications, or over-the-counter medications somebody's taking. So we're concentrating here in this situation on prescription drugs. So this is a snapshot from a prescribing information from a prescription drug called Misadventure, which is a newer drug. I just took a snapshot. It's actually something that is for hepatitis C, and it's a combination of a couple different drugs. But I took this because this can be pretty complicated. When you're looking at prescribing information, and I'll go into a little more detail about where you find it and what other highlights you can get from prescribing information. One of the highlights from prescribing information, which is for every single prescription drug out there, has prescribing information, by the way, will be the highlights of the drug interactions. This looks pretty complicated. Certainly somebody who's midway through their doctor or pharmacy program knows what this means, but you're not in healthcare, you're not going to know what this means. So moderate CYP3A inducers, strong CYP3A inhibitors, and they're not listing any specific drugs for us here. So this is where it needs a little bit more research, or you can ask a medical expert about that. But you can see there's these things known as CYP3A. These are pathways in the liver that help metabolize drugs. And some drugs that induce this CYP3A pathway speed up how fast the drugs are broken down, and those that inhibit that pathway slow it down. So if you have two drugs that are both competing in the same pathway, that's a potential big interaction. And how you address that as a healthcare provider would be, maybe you don't put them on those two drugs at all. Maybe you adjust the dosages, but make one higher, make one lower, or both. Or you just do very careful monitoring. So I just want to alert you that when you see some of these resources for drug information, sometimes it can be pretty complicated. At times, prescribing information will be a bit more specific, and if we went further into the Misadventure prescribing information, it'll list some drugs later on. This is just the highlight part, but it's not going to list every drug, so don't stop there. So what are some drugs that should come up right away when you see in a medical chart or in a pharmacy chart that are red flags for potential drug interactions? The anti-seizure drugs, the things that are used for epilepsy or other seizure disorders, those are big ones in terms of how many drugs they interact with and what their propensity is for causing drug interactions. So things like phenytoin, which is Dilantin, carbamazepine, which is Tegretol, valproic acid, which is Depakote. When you see those in there, when you have a patient on any of those drugs, look really carefully at the rest of their drugs because these three interact with a lot of different drugs. And when I talk about warfarin, I won't even go into what warfarin interacts with because warfarin interacts with just about everything. So a patient who's on warfarin, it can be so sensitive to other drugs, it can even be so sensitive to the fact that if they eat more green leafy vegetables that week, meaning their vitamin K intake has changed, it can throw off their warfarin levels and affect their risk for bleeding. Certain classes of antibiotics have a high likelihood of drug interactions. The fluoroquinolone antibiotics, so things like ciprofloxacin, these are powerful antibiotics and they certainly have a place in treating infections, but really have to look at what other drugs was the patient on. Was it appropriate to have them on a fluoroquinolone with the other drugs? I talked already a little bit about NSAIDs in terms of patients that have kidney disease, but NSAIDs can be a potential interaction, and it's not only if they have other disease states, but even if they're on other medications, let's say other things that could put them at risk for bleeding, well, NSAIDs can cause bleeding, so you don't want two drugs that can do that. The class of antidepressants known as SSRIs, selective serotonin reuptake inhibitors, these are somewhat newer. I mean, I think newer, the late 90s, they started to become popular antidepressants. And there's another similar, I would say, a dietary supplement to SSRIs known as St. John's wort. So St. John's wort is known as, nature's Prozac or the natural Prozac, because it really does exactly what Prozac does, which is the direct name is fluoxetine, and it has the same likelihood for drug interactions. It's just an aside. Lithium is another drug. It's similar to any of these other drugs, especially something like warfarin or the seizure drugs. We're actually getting levels and we're following drug levels, or we should be following drug levels closely to make sure that a patient is in that therapeutic range. We don't have therapeutic ranges for all drugs, but we do have it for lithium. And it's a very narrow therapeutic index. And so there's a lot of drugs that can throw that off. It's a very sensitive drug and it can be a very highly toxic drug. So how do we determine, do I have a question in the back? We're going to wait for questions to the end. Is there something you can wait for? You've got a burning question now.
It has to do with what you have up there with antidepressants. I just wanted to know what Paxil is.
Paxil is paroxetine. I'm sorry, that was one of the only ones that I did not give you a brand name for. When I teach pharmacy students and veterinary medicine students, I try not to give brand names because they should learn the generic names only, because that's how they should be writing their prescriptions. But then when I talk to folks outside of that, I was like, well, we have to give as many brand names as possible because that's what you know. So thank you for your question. So how is dose determined for an individual patient? Do we, as healthcare providers, just open up our reference on our computer or in our book and say, okay, this is the drug, this is the dose, that's the end of the story? It is not. Because we have to take into account how well is the patient's kidneys working. There's certain drugs where if the kidneys aren't working that well, we need to adjust the dose. We need to make it not necessarily lower. Sometimes we need to make it higher, depending on what we're trying to achieve. Liver function, the liver is the body's way of metabolizing drugs, meaning breaking down drugs. If there's a drug that is highly metabolized, meaning a lot of metabolism is occurring, a lot of breakdown is occurring in the liver's not working well, we have to take that into account. Patient's weight, most of the time it's either highly toxic drugs for adults that are dosed on a milligram per kilogram basis, meaning on a patient's weight, and most pediatric drugs are dosed on a weight basis, milligram per kilogram basis, a very precise dosing. What other drugs the patient is on, if there's an interaction like I described, that'll affect what the dose will be of a drug. Patient's disease states, I mentioned if they have kidney disease, they have cardiovascular disease, meaning heart problems, and then finally genetic factors. So what exactly are genetic factors, and we have much data on what drugs are affected by genetic factors? So when I say genetic factors or genetic predispositions, these are in no way like, genetic diseases or genetic defects or anything similar. It's just what we're trying to do is to deliver personalized medicines. You may have heard that phrase before, personalized medicine, meaning really being able to understand how a person will react to a drug, what their benefits will be, what the toxicities will be, what their response will be based on their genetic makeup. So for instance, there is one particular enzyme pathway in the liver that we have over 100 drugs that we know go through that pathway, and that we know if that person has any kind of modification of that enzyme, meaning their enzyme's not working as well as somebody else, like they're a slow metabolizer through that particular pathway. Well, if we know this, we don't start at the highest dose, or we don't even start at a normal dose at a particular drug. We go low, as low as possible, and slowly titrate up. Like for example, there's an antipsychotic drug known as Abilify, the generic is aripiprazole, and in the prescribing information, it says at the bottom there's a genetic component to dosing this drug. Now, does everybody know this about themselves? Not necessarily. It's not, I mean, these tests are increasingly available. They might be saliva tests, they might be blood tests, in terms of the different enzymes that a patient would be using to metabolize drugs. If that's in the chart and there's no indication that there's a dosing adjustment for a drug that's dependent on that enzyme, that's an issue. So for example, not to get too complicated, we'll just take the last part of this prescribing information for aripiprazole. Patients who are known CYP2D6 poor metabolizers should receive half of the usual dose. Now, what if you just don't know? You might not know if you're a poor CYP2D6 metabolizer. Your doctor might not know. Well, do you need to start at the highest dose? If you don't know and you're not planning on testing for it, start at the lower dose and work up and see how the patient responds. Very simple. More on the dose. Was the dose prescribed appropriate? Now, I already gave you one drug for an example that has a very narrow therapeutic index, lithium. There's very, very little room to play with. So you already saw lithium on the list of drugs that have red flags next to them for high likelihood for drug interactions. And you also saw a couple of these anti-seizure drugs on the drug interaction list, the carbamazepine and the phenytoin, and you saw warfarin. So you're kind of seeing a theme here. You're seeing these drugs that not only do they have a high likelihood of having drug-drug interactions, but now I'm explaining that they also have very narrow therapeutic indices, meaning there's not a lot of room to play with between a therapeutic drug level and a toxic drug level. And to push a patient into the toxic drug level is not all that hard when you have issues like other drugs on board. Cyclosporin, digoxin, these are drugs that are quite potent, and we may be getting close drug level following on them, or we may not. If I'm looking at the medical record and I'm not seeing a digoxin level on a patient for months and months and months and months, and there's being changes in their drug regimen, that's concerning. So in toxicology, there's a handful of antidotes. I mean, if there was a whole list of antidotes that could solve every problem in toxicology, I wouldn't have gone into toxicology as a specialty because it wouldn't be that exciting. So there's very few antidotes, and I'll go into what some of them are and what they're used for in a moment, because I want you to be able to recognize an antidote when you see it. So the purpose of an antidote is quite simple, is to reverse the bad effects of a drug or counteract the effects of a poison. And it's used either because there's an adverse effect happening from a particular drug and you want to reverse that, or there's been an overdose, meaning somebody got too much of a drug, either intentionally or unintentionally, and you want to block the effect with an antidote. So the antidote that you may be familiar with and you hear on the news quite frequently is naloxone. The brand name is Narcan. You might hear about it more and more because even though it is a prescription antidote for opioids, meaning things like heroin or prescription opioid pain medications, it works really well. It blocks the effects of opioids. So if the opioids are sitting on the opioid receptors in various parts of the body, naloxone comes on board either intranasally, meaning up the nose, or it goes into the muscle or into the vein, knocks them right off. And it can do bad things like put people in withdrawal, but more importantly, it could completely stop the toxic effects. You see that in the medical chart. You want to find out, why are they giving naloxone? Was this something that happened pre-hospital, or was there something that happened in the hospital that now they need to give naloxone? Did the patient get too much of an opioid while they were there. What happened? The antidote known as flumazenil reverses the effects of benzodiazepines. So benzodiazepines are things like Valium or Ativan, might be used for preoperative sedation, might even be used during surgery. Of course, they're also available in tablet and capsule form as an outpatient basis. But if you see flumazenil in a medical chart, why do they need flumazenil? Why do they need these things to reverse the effects of these different drugs? Now, there's some of these antidotes that I have asterisks at the end of their line, and that's because just because you see glucagon or glucose or sodium bicarbonate on a medical chart, that doesn't mean it was necessarily used in an antidote capacity. There's many other uses for those so-called antidotes, so to keep that in mind. Things like leucovorin. Leucovorin is only going to be used if there's methotrexate toxicity. Methotrexate is a drug used in oncology. Things like protamine sulfate is used to reverse the effects of heparin. Digifab is used to reverse the effects of digoxin, which is a heart medication. And then N-acetylcysteine, otherwise known as NAC, NAC, is used to reverse the effects of acetaminophen, Tylenol. So short list of antidotes, because there's really not a lot of antidotes out there. But if you're reading a medical chart and you see any of these things in there, dig further. Why was there an antidote given? So I get a lot of questions from attorneys about drug levels, both in patients that are living and patients who have died. What do these drug levels mean? Is it a therapeutic level? Is it a toxic level? Some of the laboratories, when they give drug level results, they may take it upon themselves to say therapeutic or toxic or cause of death or something to that effect. I don't look at that. I don't look at what their interpretation is. I want to see the level and I want to see the units. And then I want to take it from there to determine myself if it's actually something that can be harmful. Because just because there's a drug level doesn't necessarily mean you can tie it to either, okay, it's a therapeutic drug level or it's a toxic drug level. With some exceptions, remember lithium, for example, that's a drug that we have a lot of data on in terms of where the drug level of lithium falls into the toxic range and where it falls into the therapeutic range. And just because you don't see drug levels for all drugs doesn't mean that anything is wrong. It means there's not drug levels available for all drugs. And if there is one that's available, it might be one of those ones where you call for a level and they're like, well, we can get it back to you and we have to send it out and it's going to take a week. So sometimes there are drug levels that are available and they're not all that helpful. And the key thing I want to impart to you about drug levels is even if you see a drug level and it says normal, normal range is not necessarily normal, because just because something is within a therapeutic range doesn't mean it's a safe drug level for that particular patient due to a lot of factors, like what other drugs they're on, what kind of signs and symptoms they're having while on that drug, and a whole bunch of other factors. So don't kind of ignore that when you see that on laboratory tests where it says normal. Okay, you have a level, let's really see, is that considered safe for that particular patient? So when we talk about older adults, and at least for purposes of medication safety, older adults are considered 65 years of age or older. And there's a late physician named Dr. Mark Beers who put together something called the Beers List in 1991 for the American Geriatric Society, and this list is still updated today despite the fact that Dr. Beers is not with us anymore. But this list, it's more like in an article form, it's not like an A to Z list, describes specific medications and classes of medications that are potentially inappropriate for older adults. And it'll go on to say why. Well, this particular drug or class of drugs has a higher likelihood in older adults to cause falls or to cause confusion, or has too many drug interactions, or requires perfect liver and kidney function that older adults often don't have, or similar. And so this is not the black and white list. So it's not as if, okay, if you get an adult that's 75 years old and they were put on a drug that's on this Beers list, it doesn't mean automatically, okay, there's a big problem here. Because it's not this list doesn't dictate standard of care, but it should take into account, if the drug is on this list, did the physician take into account that, okay, this is an older adult who needs careful monitoring or maybe needs a lower dose of this drug that's on the VIRS list. So be aware of that list, and it's certainly worthwhile looking at it. It is available on the internet. All right, so back to the prescribing information. You saw a couple snippets from FDA prescribing information for 2 different drugs. First, the drug interaction section, and then a section about dosing based on genetic conditions. So I told you exactly prescribing information is really just, the FDA has approved a prescription drug. Along with it, the FDA has approved prescribing information. Every prescribing information has the same sections in it. It has things like drug interaction, it has dosing, it has special populations, it has pharmacology, they all have the same sections. Of course, different information for each drug, but they all have the same sections. So where do you find prescribing information? Well, I like to go, and I would recommend this to you as well, the best place to find prescribing information is the manufacturer's website. So if you know a drug is made by, let's say, Merck, you go to the Merck website and you find the prescribing information there. Yes, it's available on the National Library of Medicine site, it's available on the FDA site, but you know that in real time, the manufacturer's website is going to have the most up-to-date prescribing information to the hour. Because there may be a sudden warning, like for instance, some drugs have these black box warnings, you might have heard of them. So these are such serious warnings that they actually get put in a literal black box on the prescribing information. And it may be in the very first prescribing information when the drug first hits the market, or it might not be for months or years later that there's a black box warning put in the prescribing information for a particular drug. So these are things that you want to know, and you want to make sure that you're getting the most up-to-date. That's why the manufacturer's website is the most important. And in terms of how these things evolve, I would say I never want to buy a car its first model year. I never want to take a prescription drug the first year it's out, because if you think about it, prescription drugs are tested, in very closely monitored clinical trials. But how many patients are in these clinical trials? Maybe 3,000, maybe 5,000. But then once the drug is approved and it goes out to the general population, then you have millions of patients taking this drug, and you have it in an uncontrolled environment, meaning, when you have a clinical trial, you have only patients, exclusion and inclusion criteria for these trials, meaning if you have this wrong with you, or you take this, or you're this age, we're not going to include those patients in the clinical trials, whereas they're looking for a specific subset of patients. Whereas when it gets out into the marketplace, everybody's taking it. That's when you start to see all different types of adverse events and other interactions that you didn't know about when the drugs first came out. So the summary of that is make sure you have the most up-to-date prescribing information. So this just goes over the sections of the prescribing information just to give you an idea. There's not much to read here because it is a little bit small, but I just wanted to show you get first how the prescribing information is structured. You first get the highlights of the prescribing information. So the highlights up here are indications, meaning what is this drug for? What is it FDA approved for? That's a whole other story. Can the drug be used for what it's not FDA approved for? Sure, in an educated fashion, of course. The dosage and administration, interactions, contraindications, meaning when you shouldn't be using this drug and what types of patients, the warnings, the adverse reactions. All right, so it just gives you a very high level. Then you can read about it in the 15 sections, the preceding 20 pages of prescribing information. So I already described what clinical trials look like for drugs that are coming to the marketplace in the United States. So that's all the pre-marketing safety information that we have is just based on clinical trials. And then once the drug comes out, like I said, that's when you really start to see side effects and otherwise known as adverse effects emerge. So if you've looked at a prescribing information and you're looking for your particular case, if a drug can cause such and such reaction, just because it's not in the prescribing information doesn't mean you should stop there, because it very well could be an effect of the drug that you're questioning. It just might not have either one, been reported to the FDA enough to mandate a change to the prescribing information, or maybe it's so rare that it hasn't made it in the prescribing information. But I mean, I've seen enough in toxicology that it's not always, okay, well, it's such a common reaction, that's what we always will see. There's definitely situations where drugs have caused unusual reactions in patients and they're just not well known. Maybe it's in the literature and a case report here, a case report there. It definitely warrants further investigation beyond prescribing information if you're not finding it there. So I mentioned where to find drug information because there's certainly information for the lay public on medications and their effects, and there's a lot of not so reliable sources on the internet. But that handout I told you about gives some information in terms of what are some reliable sites. And if it's something that's made for healthcare professionals, you saw how technical it could be, like if the patient, is a CYP3A inducer or somebody who, has a CYP2D6, poor metabolism, what do those things mean? That's not going to be in that type of terminology in these particular sites. So if you're to the point where you're thinking, okay, I've done my detective work, now I'm looking for a medical expert, who am I looking for? So even among attorneys that I've worked with who have worked with toxicologists before, they don't always know what I do as a clinical toxicologist versus what a forensic toxicologist would do and that sort of thing. And I certainly have referred attorneys to colleagues of mine because it's not something that is a specialty of mine. So I'll go a little bit about what the different types of toxicologists are. So I'm a clinical toxicologist, meaning my specialty is understanding how drugs and poisons work in patients and being able to treat and recommend how to treat poisoned patients. I also do some work post-mortem in terms of determining significance of post-mortem drug and toxin levels and how they may or may not have contributed to the death of that particular patient. Medical toxicologists do the same thing as clinical toxicologists, but their backgrounds are different. So I have a doctor of pharmacy degree, I'm not a physician. Medical toxicologists are physicians, and they are often emergency medicine physicians who have additional training in toxicology and then are board certified in toxicology, as I have. The big difference is that they are physicians, so they can comment on standard of care. So if there is an issue where you want to know not only about toxicology issues, but what would have been the appropriate standard of care, for a patient, let's say in an emergency medicine setting, that would be a medical toxicologist. Reproductive toxicologists, these are toxicologists that have specialized knowledge and training regarding how drugs and toxins can affect unborn babies. It's a very specific area in toxicology, not one that I have a specialty in. Forensic toxicologists can be either more like clinical toxicologists. I know several forensic toxicologists in my circle in clinical toxicology, but there's also forensic toxicologists that do not see living patients and do not interact with living patients, and they are very knowledgeable, let's say, about laboratory equipment, what's the appropriate test to run, and how to interpret it, and they're specialized in postmortem. So forensic toxicology and clinical toxicology have some overlap, but in terms of really drilling down about the laboratory science in toxicology, that's often a forensic toxicologist, excuse me. So in terms of which is your best bet, once you figure out what the right specialty should be, and hopefully your medical expert will be upfront with you about their qualifications in terms of how many poison patients have you treated? How many poison patients have you been consulted on in terms of the care of a poison patient? Do you have board certification? I've seen opposing experts of like, wow, they're really smart people, but have they ever seen a poison patient in their life? And do they have experience with the particular case that you were interested in? I've certainly gotten cases where it's either in my realm or it's not in my realm of expertise, and you want to make sure that you have that conversation in terms of, tell me about your experience with this. And finding a toxicologist, referrals from your law colleagues, obviously there's expert witness directories. So this number for the Poison Control Center, this directs you to the closest one. So if you have a phone that has a Philadelphia number or a Delaware number, it's automatically going to route you to the Poison Control Center in University City at CHOP. If you have, let's say, a phone number that has a Pittsburgh exchange, even though you're sitting right here in Philadelphia, it's going to route you to the Pittsburgh Poison Center. But as an aside, you can call the Poison Control Centers, and they have medical and clinical toxicologists. And it varies in terms of how many medical and clinical toxicologists that work at Poison Control Centers do expert witness work and litigation consultations. I personally did not do it when I was at CHOP. First of all, I was super busy being a poison center director, first of all, but also, I was always concerned if there was any conflict of interest somehow coming back to CHOP or coming back to Penn, so I did not do it, but some are certainly able to do that. And then there's various professional organizations for toxicologists. The American College of Medical Toxicology has a referral service, and I'm a member of the American Academy of Clinical Toxicology. They don't have a referral service, but there's certainly a group that you can call. And I do 15-minute curbside consults free of charge. So curbside consult is a term that we would use in the hospital to say, hey, I'm not going to tell you a lot about this patient, but here's just a description at a very high level. So I can, first of all, see if I think I can help you. Also to help you figure out, is it a viable case? Sometimes with a 15-minute curbside consult, we can both come to a conclusion on both sides. So as promised, I concluded in advance of 6:30. So we have 5 to 7 minutes for questions. You can either ask questions now, preferably, so your colleagues can hear your interesting questions, or you can certainly come up to me after, before 6:45. So thank you for your attention. So am I really going to be let off the hook with only a question about Paxil? Is that it?
There's such a drug called Librium,
There is.
and what was it used for? What
So
is it used for?
benzodiazepine, that's a brand name. I want to say the generic is chlorodiazepine epoxide, but I'm not sure on that. That's an old drug. That's one of the older benzodiazepines. I think it was used for anxiety. Yeah, it was a benzodiazepine, so anxiety or sleep.
It was like Valium, I think.
Yep, in the same class of drugs. Yeah, one of the older benzodiazepines.
Is Paxil the same as what was it, Prozac?
Prozac is fluoxetine. It's in the same class though. I mean, there's some subtle differences between the two of them,
Okay.
but they're in the same class. Yeah, I did a lot of work with Paxil. My internship in my first job out of pharmacy school was with what used to be called SmithKline Beecher. And my role was in the drug information department, pre-launch of Paxil. So I was doing all the, dear doctor, thank you for your question on Paxil. Here's information on, use for weight loss, or here's information for use in pediatrics. I did all the pre-form letters for Paxil.
Well, did you find in your studies that Paxil caused patients to gain weight?
It can go either way. Some people were gaining weight, some people were losing weight, and it was the question of, was it because of the drug, or was it because their depression was getting better or worse, or what was the situation? But yeah, that they vary, and I'm not an expert on the weight gain part, but for the SSRI class, there's variation in terms of which ones of those cause weight gain or weight versus weight loss. Yes?
Our hospital record system is moving towards trying to automatically look for those drug interventions and counter indicator. These should be going together to alleviate interns and doctors from the OPSIS, like the machine catch this.
That's a great question. Yes, they are, but there's pluses and minuses to that, because if you've been to a doctor lately or been in a hospital lately, they're not looking at you. They're trying to talk and type at the same time. So they're trying to make these electronic medical records, more patient friendly in terms of making it easier for us to enter. But then when there's all these things that are coming up, like let's say there's an interaction, they're trying to make it harder to override that because you just kind of have this, trigger finger to override. So there's like a plus and minus, like you want to make sure that you're being alerted of these drug interactions, but you don't want to make it too easy to override it either. So there's that, time factor. But yes, they're trying to build in patient safety factors like drug interactions, or they'll have flags and they'll say like inappropriate dose, based on the patient weight or the patient age in the system. But yeah, they're not perfect. There's no substitute for just being able to practice good medicine. Yes.
And forgive me if you went over this before, but I dealt with a case where the pharmacist took a prescription for a Haldol, which is some serious stuff, and instead of making, I think maybe 1 pill every 4 hours, it was like 4 pills in 1 hour, which turned the guy into like a wooden board in a sense. It's terrible. How common is that kind of screw up? Can I ask?
Well, if he was entering, or he or she was entering it into the pharmacy computer system, maybe there was a flag that said inappropriate high dose, but he's got a stack of prescriptions like this. He might have, override. In a perfect world, what would have happened is that, wait a second, this is not a normal prescription that I'm used to seeing, or maybe I don't know the dose of Haldol off the top of my head because I'm a new pharmacist or don't get many Haldol prescriptions. That's when you call the prescriber, consult your reference. If something doesn't sound right, you don't just override it, you look. So yes, that could definitely happen, and the computer system may or may not have flagged it, and it may or may not have been overridden.
I guess maybe my question is it a common mistake for the transposing of, again, 1 every 4 hours?
Oh, the transposing.
Right, because I can imagine myself doing that if I were a pharmacist.
That I don't know. I've practiced pharmacy somewhat, but not ever full time. So yeah, I don't know what the breakdown is in terms of like where the different errors. People have definitely studied that, like where would the errors be most likely to occur, and are transposing errors one of the types of errors. So that I don't know. Yes.
Language access is always a big issue for me personally, so I can see it's very difficult for medical professionals to get accurate medical information when the patient doesn't speak good English, or they brought their medications from Russia, India, whatever, and it's in English and it's not generic. How do hospitals handle that?
Well, I can speak to my experience at CHOP. We had translators available 24/7. We had they have a language line. And there are languages that I've never even heard of that are available on this language line. And they do the conference call, or the patient's right there, they have the phone right there. If it's foreign prescriptions, meaning it's drugs that are not sold in this country, or we are not familiar with the drug at all, the reference I always used to use was Martindale's. It's a foreign drug equivalent, so it'll tell you, okay, this drug is an NSAID, this drug is this, so you'll be able to figure that out. And in terms of the smaller hospitals, like the non-academic institutions, I don't know if they have that luxury of having 24-hour language access, or if it's required. That I don't know.
My county doesn't have it, trust me.
Oh.
All right, thank you.
Yeah, my question was, if the person doesn't speak English, how are they supposed to tell you what language you need to ask for? And it was always fascinating because they would get on the phone with the language line, they meaning the patient or the family, and just from speaking the language, the person on the language line would be able to figure out which language they're speaking, even if that particular person didn't speak themselves. It's very interesting. All right, well, thank you everybody for coming.